Okay, Denise, it's 8:03, so why don't we get officially started and start running through the slides and the housekeeping. Okay, so I've already introduced myself. Welcome. I'm a geriatric psychiatrist in Toronto, Canada at Baycrest. We're fully affiliated with the University of Toronto, and I have the pleasure of chairing the Journal Club. And welcome to our presenter today, Dr. Kae Ito, who I'm pleased to introduce. Dr. Ito is a doctor of medicine at the Tokyo Metropolitan Institute of Gerontology and is part of the research team for human care. And Dr. Ito's interests include issues of clinical ethics in relation to older people with complex health and social care needs. So welcome, Dr. Ito. Just in terms of some basic housekeeping, please use the chat feature to ask your questions at any time. Depending on the flow, we might save some of the questions for the end. Dr. Ito's presentation of the journal article will take somewhere like between 15 and 30 minutes, so there'll be lots of time for discussion. But please feel free to use the chat, and we'll decide if now is a good time to ask the question or if we will leave it towards the end. And all attendees will be muted with their video off for the presentation. So you're invited to turn on your microphone during the discussion. In fact, depending on your comfort level, I think it would be great for people to put on their cameras and microphones. Also, I'd encourage you that if you'd like, in Zoom, you can, you have your name, but if you'd like to put where you're from, that would be great as well. So that's a good option. If you have any difficulties logging on or logging off, please just let us know. And the Journal Club presentation is being recorded and will be posted on the IPA Learning portal. Just to remind people that this is a CME, Continuing Medical Education certified program, and there's no financial or commercial support that was received. There'll be an evaluation for the learners to complete to receive a certificate of completion. There's a list of other types of credits that you can get for continuing education. If you have any questions at all, please contact the Secretariat from the IPA. Today, our learning objectives will be that after the end of the programs, learners will be able to learn about the method of first conducting an analytical framework and then analyzing using that framework. Consider the challenges of investigating the impact of neuropsychiatric symptoms and dementia progression rate, and consider the arguments needed when discussing the differences between the findings of previous studies. And there are no disclosures. I think we already saw this slide. Yeah, great, so thank you. I think we'll get started, and Dr. Ito, over to you.
Okay. Thank you for presenting me, Dr. Madam, and I'm Kae Ito from Japan. Today, I would like to present a paper by Dr. Edmin published in 2020. First of all, I would like to talk to you about why I chose this paper. Predicting the dementia progression rate is an important part of everyday clinical practice. We spend time with your patients and share with them what is going to happen a little further in the future so that we can set up the necessary supports that they will need. In this case, the situation is not so urgent that the prediction of the dementia progression rate must be made right now. However, there are situations where you have to think about the dementia progression rate in patients you don't know very well, in situations where you're not even given enough time for observation. An example is the consultation liaison psychiatry situation. For example, when psychiatrist is asked to support a patient with dementia in cancer-related decision-making. The decision to have or not to have surgery for cancer usually requires an immediate answer. And this is becoming no longer an exceptional situation. because more than 90% of people with dementia have one or more physical comorbidities, and an increasing number of people with dementia have cancer. And decision making regarding healthcare for people with dementia is increasingly discussed in relation to decision making capacity of people with dementia. However, when it comes to informed consent, it is not only a question of the patient's decision-making capacity, but another important point is that the healthcare provider should provide the appropriate information. For patients with dementia and cancer, it should be necessary to share not only information about the prognosis of cancer, but also information about the prognosis of comorbid dementia. And sometimes the dementia progression rate needs to be taken into account. Cancer-related decision-making in people with dementia is more difficult than people without dementia. This is partly because we need to consider the impact of dementia on cancer treatment and prognosis. For example, if very early stage stomach cancer is detected at the stage when dementia is progressing and oral intake is no longer possible, surgery may not be an option. This is because dementia, not cancer, is likely to determine the patient's life expectancy, and it is expected that the patient will not suffer from cancer-related symptoms in the period leading up to death from dementia. On the other hand, advanced colorectal cancer may be diagnosed at an early stage of dementia. It is known that cancer is often diagnosed in an advanced stage in people with dementia. Surgery may be an option if the cancer was already causing obstruction to the passage of the colon. Or if the prognosis is likely to be defined not by dementia but by illness caused by colorectal cancer. Because when illness occurs, there are of course unpleasant symptoms such as nausea and vomiting, and there is a risk of rupturing if the patient does not notice or cannot communicate the signs of illness, which may be painful for them. Oh, sorry. These are the cases that are relatively straightforward to determine, but the difficult cases are those where it is difficult to determine whether the progression of dementia or the progression of cancer defines the patient's life expectancy. In such cases, the dementia progression rate must be considered when making cancer-related decision-making. It is known that the life expectancy of people with dementia is shorter than the people without dementia. Furthermore, it has been reported that cancer patients with dementia are more prone to complications for treatment and have a shorter life expectancy. It is important for geriatric psychiatrists to be able to consider the impact of dementia on the treatment and prognosis of serious illnesses, such as cancer, and to be able to support people with dementia appropriately when they're making decisions about their health care. And previous studies have shown that factors associated with rapid progression of dementia include older age, lower cognitive function, heavier neuropsychiatric symptoms burden, early appearance of extrapyramidal symptoms, having both signs of Alzheimer's disease, dementia, and Lewy body dementia at baseline. And the study I'm going to present today is a study that clarified the association between neuropsychiatric symptoms and the dementia progression rate. Participants of the study were patients diagnosed with dementia at the memory clinic of Oslo University Hospital between January 2009 and July 2016. and those included in Norwegian Registry of Persons Assessed for Cognitive Symptoms. And the follow-up period was up to 3 years in order to limit survival bias, and the average follow-up period was 2.2 years. The patients had at least one follow-up examination after baseline period, which was 6 months. To identify NPS clusters, factor analysis was applied to the 20 items of the NPIQ scale. 3 clusters was identified. Agitation symptom cluster included elation, euphoria, disinhibition, agitation, aggression, irritability, lability, and motor disturbance. An affective symptom cluster included anxiety, depression, dysphoria, nighttime behaviors, apathy, indifference, appetite, eating. And psychosis symptom cluster included hallucinations and delusions. And the results. In a previous study, the authors had identified 3 distinct progression trajectory groups. Different assessment scales are used to measure dementia progression. For example, MMSE, CDR, or ADLs, length of time to nursing home admission, or length to time to death. As the CDR measures both cognitive and functional abilities, the authors used the CDR. In this study, the CDR sub-items were added together as the CDR sum of boxes to form a continuous scale of 0 to 18. Group 1, represented by the blue line, had the best baseline functioning and the slowest progression rate. The average annual change in CDR sum of boxes was 0.7. And Group 2, represented by the red line, and Group 3, represented by the green line, both progressed faster. The annual changes in CDR sum of boxes was 2.4 and 2.9 respectively. In the present study, multinomial logistic regression analysis with the 3-level trajectory group as the outcome variable were performed. Characteristics of the participants are shown in this table. Average age was about 70 years old, and about half of the participants was female. Mean education years was 12 years, and about half of them had Alzheimer's disease, and another 20% had etiologically mixed AD. The MMSE score and TMTA score and CDR sum of boxes significantly differed between the 3 groups. And NPIQ severity and all 3 NPS clusters severity also differed significantly between the 3 groups. In relation to NPS cluster and the etiology of dementia, the patients with FTD showed more agitation, and those with Lewy body dementia showed more psychotic symptoms. This table shows the prevalence of comorbidity by group. There were no significant difference in the prevalence of comorbidity groups between the 3 groups, except for psychiatric disorders. The frequency of psychiatric disorder was highest in Group 1, which was less severe at baseline and most slowly progressive dementia, and lowest in Group 3, which was most severe at baseline and most rapidly progressing dementia. Multinomial logistic regression analysis adjusts for age, sex, length of education, dementia etiology, and cognitive function were performed. Based on the author's previous study, MMSE and TMTA were used to adjust for cognitive function. A multinomial logistic regression analysis were performed adjusting for age, years of education, dementia etiology, and cognitive function with NPS clusters entered separately. The NPS clusters with p-value smaller than 0.2 were then retained. And for comorbidity, 12 disease categories were selected based on the result of systematic review. Multinomial logistic regression analysis were performed, adjusting for age, sex, years of education, dementia etiology, and cognitive function, with comorbidity groups entered separately. The comorbidity groups with p-values smaller than 0.2 were then retained. Here are two final models for the multinomial logistic regression. One was adjusted for age, sex, length of education, dementia etiology, cognitive function, and comorbidities. This model showed that affective symptom clusters and psychosis symptom cluster at the time of dementia diagnosis increased the relative risk for rapid clinical progression. The result that psychotic symptoms increase the relative risk for rapid clinical progression is in accordance with studies which found psychotic symptoms to be associated with rapid cognitive decline. About affective symptoms, results vary between studies. This discrepancy may be due to the overlap between symptoms of AD and depression, and because depressive symptoms often occur with other NPS, making the diagnosis challenging. And another final model was adjusted for age, sex, length of education, dementia etiology, cognitive function, and NPS clusters. This model showed that previous diagnosis of mental and behavioral disorders, excluding dementia, reduced the relative risk for rapid clinical progression. So the key point of this study was psychotic and affective symptom clusters at the time of diagnosis were associated with rapid progression of dementia. And previous diagnosis of mental and behavioral disorders, excluding dementia, were associated with slow progression of dementia. And these results support the needs for individual assessment and follow-up protocols. And in the context of the first discussion, which relates to decision-making regarding treatment of physical comorbidities, it is a very beneficial finding for geriatric psychiatrists that NPS can help predict the progression of dementia, even more so in situations such as consultation liaison psychiatry, where it's difficult to obtain a detailed medical history. And that's all from my presentation. Thank you.
Okay, thank you very much, Dr. Ito. So we've got lots of time for discussion. Let me just get to the gallery view. And yeah, so feel free if you're wanting to make a comment or ask a question, you could put your comment or question in the chat. Likewise, you can unmute your microphone and say what you'd like to say, ask any question you'd like. Of course, if you'd like to put on your camera, and we'd all be happy to see you as well. So questions, comments, concerns about the findings? Was there any surprise here? How do we make sense of all of this in the context of our day-to-day work? Any concerns about the methodology or confounds? What are people's impressions?
Thank you so much for your presentation. I was wondering, is the reason why the group, I guess group 1 that had the slow progression, and then we saw that they were different because they had comorbid psychiatric disorders, is the hypothesis there that perhaps their cognitive impairment is secondary to partly just the comorbid psychiatric disorders, and therefore has less of a progressive decline. I don't know if they commented on that.
Let me think. Like when people with schizophrenia or intellectual disability have slower progression of dementia, and that matches with the sense of clinical everyday clinician, but maybe the etiology is a little bit different from like Alzheimer's, and the change in the brain is occurring very slowly. That's just my impression.
Yeah, thank you. That makes sense.
So that was a bit of, I don't know if it was a surprise. It was a bit of a surprise because we know that, for example, having an episode of depression in your life increases your risk of Alzheimer's disease.
Mm-hmm.
And it makes you wonder about the nature of psychiatric symptoms. For example, well, it's like the patient we saw today, Alex, was that a lady who has mild cognitive impairment and is probably developing early dementia, who's presenting with, well, would you call it depression or a mixed episode as part of a long-standing mental health disorder? Or is it something different that you would call a neuropsychiatric symptom or BPSD? And, I guess what this study is showing that at the time of diagnosis, psychiatric symptoms seem to be associated with a rapid decline. But so many of our patients have had premorbid or long-standing psychiatric illness, and you might be talking about two very different processes. Why would an episode of depression early in life be associated with a higher risk of dementia later on? But it might have to do with the proximity to the dementia. In other words, if you have depression when you're 25 years old versus depression for the first time when you're 80 years old with cognitive decline, might be two very different processes. Yeah. Thank you for that question. Well, any other thoughts about it? Was anybody else surprised, or does anybody else have any other understanding of why it might be that people with premorbid psychiatric illness were in group 1 in the end instead of group 3 or group 2? So anybody else surprised about it, or anybody else have any thoughts about that? Yes, Dr. Akita.
Thank you for your wonderful presentation, Dr. Ito. And I have the same surprising and question. And but in my experience, some sort of the late onset schizophrenia or delusional disorders patients showed the declining of the cognitive impairment and moved toward the MCI and dementia, but their progression is sometimes very slow, very, very slow. The process sometimes 10 years or 20 years. So maybe some patients like that are mixed in your cohort. It's my impression. But as Rob said, maybe brain mechanism or the neural basis might be different of the typical dementia and such late onset psychiatric disorders patients, I think. Thank you very much.
Thank you, Dr. Ikeda. So we saw a regression analysis. When we read this statistical design, I'm always happy to read the methodology. And then they talk about statistical analysis, and that's where sometimes I have trouble. It can be challenging, but I understand most of it. And here they were doing logistic regression analysis, I guess, to control for confounds. Do we feel as a group that it was well done, or were there other confounds that people worry about? Does anybody worry about the mix of patients? I think they were mostly Alzheimer's. But that's representative, I think, of most people with dementia. The bulk of people with dementia have Alzheimer's, and then there's Lewy body, mixed dementia. So were there any concerns around the representation of the sample? Was it representative of the usual patients? Do you think it should have just been Alzheimer's patients or all comers? This was all comers. Was any worry about other potential confounds? Do you have any thoughts about any of that?
Did they comment on medications? I don't recall.
There is no comment on medication in this paper.
Yeah. What are your thoughts, Dr. Zurikin, about the medications? You think it could potentially affect the results?
Yeah, I mean, whether they were on cognitive enhancers or not, or depending on if they were on antipsychotics with anticholinergic effects, or just really any medication that could affect the progression like that. Benzos.
Benzodiazepines. Yeah. I guess in this type of research, would it have been easy or hard to collect that data? It probably would have been easy, I think, right? It doesn't look like, it looks like the collection of this data would not be so difficult. But some of it was a database through, I guess they have a database, but there are ways to look for what pharmaceuticals, what medications are being prescribed. That's not always challenging. It depends on where the study is done. But that's a very good point.
Yeah, I agree. That's a very good point. And for example, in my generation, they say the third generation's antidepressant is a negative effect of such a cognitive abilities. But on the contrary, they say that, as you know, some of the SSRI or SNRI have the protective effect for the neural generation. So maybe in future study, we should think about the medications carefully. Thank you.
It's such a good point. There was another recent paper about the positive effects of lithium on cognition. And of course, it's not the most widely used. I don't know how widely it's used. Manabu and Kae, in Japan, is lithium used a lot? Because
yes,
in North America,
really,
yeah,
in Japan, the lithium is still the first line of medication for mania type of the patients. Is it true, Dr. Ito?
Yes, it is, and it's very problematic for older people because of the toxic effect for kidney, but it is in first line still.
And I'd say in Canada and the United States, it's not used nearly as much as it used to be. Prescriptions for lithium, certainly in Canada, have declined over the decades, while prescriptions of other medications like antipsychotics have increased. And I'd say probably valproic acid, for the reason being that some of the challenges of using lithium, having to monitor in kidney function levels, dealing with drug interactions, and the possibility of toxicity. We see that, and you could correct me, Alex, but I think most psychiatrists nowadays, when they see somebody who has a bipolar disorder, don't automatically put them on lithium. They could end up on an atypical antipsychotic as a mood stabilizer, and there's probably adequate evidence to justify it. I don't know what other people are finding on inpatient units, but Alexandra, I bet you can go through a whole residency in Toronto without putting somebody on lithium even once, I bet. Yeah.
Possibly, yeah. I think definitely we like the atypical antipsychotics. And then lithium can be started sometimes in conjunction or later as maintenance, but on inpatient units, a lot of antipsychotics.
Yeah. And we use lithium for treatment refractory depression. Often people who have a family history of bipolar disorder, but they have treatment-resistant depression, often will try lithium, and lo and behold, suddenly they're much better, they're cured. So lithium is an interesting medication. And I think if we look at this sample, if we did take a good look at their medications, I doubt there'd be a lot of lithium. And I don't know how it's used in various countries, but the protective effects of lithium are very interesting. And I wasn't aware that the SSRIs had beneficial effects as well. So that's very interesting to know. It's great.
I was just going to comment on, first of all, thank you, Dr. Kae Ito, for the presentation. I have a quick question for you. My screen wasn't so great. I've got a cracked screen, missed your methods and description. Couldn't really follow that because it wasn't showing on my screen. But before then, I wanted to make a quick comment on Dr. Zurikan and Dr. Madden's comment about the use of more antipsychotic in Canada, especially in the inpatient unit. One would think that is, pragmatic though, given that lithium does have a relatively slower onset. Say you had a manic presentation about 10 days or later. With the antipsychotics, you're able to get that initial, sort of calming. But what explains why it's not used at all or relatively used less? I can't, obviously, I don't know much about Canada, but I thought it was a pragmatic way to approach things in the inpatient unit, really, because many times it would be a manic, hypomanic, agitated patient, when you're treating bipolar specifically. But just going back to the presentation, again, apologies, I couldn't follow your methodology, so you might have already covered this, or this may not be relevant. I was just wondering, and this also ties in with an earlier question about whether or not medications was considered. I was wondering whether all the patient participants in the study already had pre-existing dementia, and we're sort of looking at their trajectory of progression, or whether or not the study also considered the fact that, dementia can, say rapidly develop even within 3 months after radiotherapy to the brain, for instance, whether or not, the dementia came gradually due to the cancer treatment itself. So again, it may not be relevant to your study depending on what your methodology was and your recruitment. But I mean, the study, not your study. I think the paper you presented. Do you have any comment on that, or have I just asked something totally alien to your presentation?
Okay.
Just whether or not, in terms of the progression, was there any consideration of the effect of cancer treatment itself on, the progression? Perhaps maybe some of them developed the dementia within a short space of time due to that, or were they already all pre-existing patients with dementia and then had cancer and other sort of comorbidities?
Okay. Thank you for your question. The patients I met in consultation with psychiatry were originally people with dementia and who had cancer
Okay.
afterwards.
Okay. All right. So that answers that. Thank you so much.
Mm-hmm. Thank you.
It's an interesting question. Victor, where are you from? What country?
Australia.
Okay, thank you so much for joining us. It's a pleasure to meet you. Considering the effect of cancer treatments on the persons with dementia, I'm not aware of the literature. And Dr. Ito, you obviously going to know more than I. But I've always wondered about the effects of certain medications and drugs on the brain, narcotics, chemotherapy. I always wondered about what chemotherapy will do for somebody with mild dementia. And I just don't know the answer, and I don't know if anybody knows. Does chemotherapy have a negative toxic effect to make dementia progress rapidly? I don't know if there's ever been a study, but it's an interesting question, sort of. That's what Victor's kind of bringing up here.
Okay. It's just my impression, but the chemotherapy would be a great risk of delirium for people with dementia or MCI because their brain function is very liable.
So when we talk about the getting informed consent for chemotherapy for someone with mild dementia, be somebody who still functions a little bit, could still interact with their family, still has quality of life. The decision about providing chemotherapy for a possible treated cancer could be a very difficult question in early stage dementia, maybe not in late stage. I don't think that's as much of and I have some patients who are have severe dementia, who are full code, meaning that no matter what medical thing happens, they want treatment, or the family wants. So I guess in making decisions, and it's hard to assessing capacity, what were the person's pre-existing wishes before they developed dementia? What is the philosophy of the family and their understanding of the wishes of the person with dementia? What is the knowledge base of the clinicians who are offering the treatment? It sounds very complicated. I wonder if anybody has any other experience with treating people with dementia or even MCI with chemotherapy. I haven't. I personally have not. That's interesting. Dr. Zarikian, do you want to mention what you wrote in the chat here?
Yeah, I saw CL case today, and we're being consulted just for for wandering, some responsive behaviors. But I was just reading in the chart that the dementia was diagnosed a year ago, and the history was a 3-month cognitive decline that coincided with the start of a chemotherapy agent for prostate cancer. And likely there were some mild cognitive symptoms before that even, but it's really with the start of that medication that the decline became more rapid and the patient had to be admitted to hospital. They're also thinking of a delirium, but like when the delirium cleared, the cognitive impairment remained. So yeah, it's interesting. I just saw a case today.
Okay, it's always challenging to see cases of rapidly progressive dementia. They're scary. You always wonder if you missed something. And the medical workup for a rapidly progressive dementia is actually very complicated. As a geriatric psychiatrist, I specialize mostly in dealing with neuropsychiatric symptoms of dementia and in depression, anxiety, those types of things. But when I see a case of rapidly progressive, I'm very quick to say, this is rapidly progressive. I need to call in someone who really knows what they're doing. And I call my friend, Dr. David Tangway, at one of the local hospitals, who has a very sophisticated method of trying to diagnose any reversible causes for a rapidly progressive dementia. And it's fascinating. If you ever want to read some great paper, Dr. David Tangway, I'll put his name in the chat, rapidly progressive dementias is his thing. So let me just put that there, David Tangway. He's in Toronto, Canada. I only know local, but it's just some. Oh, sorry, it's Tangway. David Tangway.
I have a question to Dr. Drakian. In Canada, is chemotherapy generally given on an outpatient basis or inpatient?
Yeah, so my knowledge is not the best, I will say, but I do know that there are the two options. There's PO chemotherapy medications that the patient takes at home, and then has follow-up with the oncologist. And then I know that they can also come in and get infusions. So there are the two types.
Mm-hmm.
Yeah.
They wouldn't be admitted to the hospital and sleep in the hospital. If they came for chemotherapy, they would spend a few hours in a clinic getting chemotherapy intravenously. And there are some cancers where you're prescribed oral medication at home. I don't know if that was the question. But...
Because
okay.
The chemotherapy in outpatient basis, I think it helped many people to many people's quality of life was improved because they did not have to admit to the hospital. But it's making it difficult for dementia people, especially living alone, to have chemotherapy because they can't come regularly to hospital, or they can't regularly take medication, and that will lessen the effect of the chemotherapy. So I think it's very difficult situation for them.
Well, Dr. Ito, we've stumbled upon, it's a great paper. We've ended up in a very interesting conversation because we could easily get into the ethics and legal aspects of treating someone with dementia with chemotherapy and talking about their ability to consent. And there are these thoughts also. So in Canada, we have medical assistance in dying. Mm-hmm. You could call it euthanasia, doctor-assisted suicide, but we call it medical assistance in dying. And there's a big discussion about whether or not you can provide consent for medical assistance in dying when you're either, when you don't have dementia, or if you're in the early stages, for when later on you end up at a certain point. And again, I don't know what that point is. It could be when you no longer recognize your family, or if you're distressed, or if you have neuropsychiatric symptoms. I don't know. Where your pre-existing wish was, if I ever reach that point, I would like medical assistance in dying. And it's a bit controversial, because who is the person? The current person with dementia, is that the same person that was 5 years before who consented? And how do you measure the quality of life? And all of this is a very interesting question. And I think when you start talking about consent for chemotherapy, which is not always pleasant. I mean, if you're diagnosed with cancer, you're cognitively intact, you can make an informed decision. What stage of cancer? What is the chemotherapy? How much time will it give me? What quality of life will I have? These are all very interesting questions that you want to know. And it's hard to make those decisions possibly to truly understand and truly appreciate in the context of dementia. Then you have a family member making that decision who really better understand what your pre-existing wishes were. And are you the same person? It's very complicated. That's why in our hospital, we have an ethicist. We always have an ethicist. And the ethicist is very busy dealing with all sorts of questions around capacity, consent, and some of the ethics around these decisions. Anybody have any thoughts or experience with this? Because it's a big challenge. Well, I see lots of nods, so I agree that it's probably a big challenge. Okay. Well, I see that we're at 50 minutes, so I think we could probably stop here unless there's any final questions or comments. Does anybody have any final questions or comments? Okay, well, hearing none. So I'd very much like to thank all of you for coming today. I want to especially thank Dr. Ito for volunteering to present this paper today. And so this was our fourth International Journal Club. We've tried them at different times of the day, and we chose this time to be inclusive, and we're going to keep at this. So I want to thank you all for coming. I hope that you will take a look at the IPA products and services. We have our amazing debate series. We have webinars. We have our journal club. We've got the IPA Congress. We have the Awareness Week. So most of our products are recorded so that you can watch them. And so we appreciate you coming, and hopefully you've had some fun. And it was nice to meet you guys. And thank you again. Have a good evening, or have a good day. For me, it's evening. Have a good day.
Thank you.
Have a good night.
Bye.
Bye-bye.
Bye-bye.